Good evening, dear colleagues. Welcome to this presentation on the use of lung ultrasound in COVID-19 patients. I'm going to talk you through the use of lung ultrasound in general in critically ill patients. And at the end, I will focus on the use in patients with respiratory failure and COVID-19. So we know from our experience that lung ultrasound could be useful to monitor progression and guide weaning from the ventilator. It can also help us monitor recruitment and response to proning and help weaning from mechanical ventilation. And interestingly, if we look into the literature published online, and we can see, therefore, the exponential increase in the number of publications. And if we could put in the search box on PubMed the word lung ultrasound, we will then notice the significant increase in the number of publications in ultrasound. So the principles of ultrasound, I'm sure that many of you are quite familiar with that. Ultrasound is not transmitted through aerated tissue. Normal parenchyma is not visible. Interface between the pleura and the lung is the interface which reflects the ultrasound beam, and our acoustic window the intercostal space. And coming to the advantages of lung ultrasound, we know that ultrasound is immediately available at the bedside, repeatable, can be done repeatedly as a monitoring tool. It is a rapid tool to be utilized as a focused, goal-directed point-of-care application. It can reduce costs, and it does reduce cost as compared to our other imaging modalities. And importantly, it reduces the risk of radiation exposure. And especially in COVID-19, we know that it is safer for those patients to have the lung ultrasound to reduce the need for them to move out of the bed space, being exposed to radiographers and going for having a CT scan. So moving next to the equipments required, these are the important ultrasound transducers that we can use for scanning the lungs in patients with COVID-19 and doing the ultrasound scanning in general. The universal probes are the linear probe, the high frequency probe, which is a probe that is used to scan the pleura, and the curvilinear probe is the probe known commonly as the abdominal probe, is a low frequency transducer, so it has a depth of penetration, and it is important and useful to scan the parenchyma of the lungs. But if we don't have the curvilinear transducer, we can use the cardiac phased array transducer here at the top instead, knowing that it is not as good as compared to the curvilinear probe in terms of showing the delineation of the pleura, although looking deeper in structures. So the next will be talking about the systematic scanning zones, and it's important to put in our consideration that there is no validated scanning protocol yet, but this is one of the simple protocols that I use in my daily practice, in which I divide each lung into 6 zones, and the zones are divided by horizontal imaginary line running across the nipple line, and anterior line, which is the parasternal line, the anterior axillary line, posterior axillary line, and the paravertebral line posteriorly. And this will give us 2 anterior zones, 2 lateral, and 2 posterior zones. It might be challenging and difficult to get very posterior in supine critically ill patients on the ventilator who are quite sedated and paralyzed, especially in the setting of respiratory failure. But I would always advise trying to get as posterior as we can, because this is where the devil hides, where you could often see the consolidation or the atelectasis. And then moving to the location of the probe. So depends on what we are looking for. If we are scanning looking for pneumothorax, we can put the probe in the mid-axillary line, second intercostal space as a starting point with the indicator to the patient's head, and this is our linear probe. And when we do that, we will see a specific pattern we will discuss in the next few slides. But on the other hand, if I'm looking for heart failure and signs of interstitial edema, I will focus on looking at the dependent zones and also doing a systematic protocol for all areas of the lungs. And if I am looking for pleural effusion, my aim will be putting the probe, like in this picture, in the mid-axillary line with the indicator to the head, and we could expect, because we are scanning for deeper structure, that this probe is the curvilinear probe or the cardiac probe. So it's a low frequency transducer. And when we put the probe in this location, we have the diaphragm as our anatomical landmark, and we would expect to see below the diaphragm on the right side the liver, and below the diaphragm side this plane. So starting with the analysis of the artifacts, what are the normal artifacts that I expect to see? Remember, I just told you about the linear probe mid-axillary line. When we put the linear probe mid-axillary line with the indicator to the patient's head, the first thing you would see is the bat sign, in which you see the two rib shadows appearing as black shadows laterally and the pleural line in between. Yeah, and you could also see normally a normal mirror-shaped reverberation artifact at equal distance from the pleural line, which are named A lines, and they reflect the presence of normal aeration in most of the situations. And you could also see here in 2D the sliding of the two layers of pleura. You will not be able to see the two layers separately in normal conditions, but you will see the shimmering motion of the layer of the parietal and visceral pleura together, like here. This is called the bat sign. Why it's important? It takes the shape of the bat, and it's important initial identifying position, because this is how we confirm that this bright line is the pleural line, not any of other these white lines, which are basically part of the chest wall. And the bright line here is connecting the two rib shadows. So it's important to start in this position. Once you confirm the pleural line, you can rotate the probe in a horizontal position or oblique position to be in line with the pleura. And then going forward, uh, different examples of sliding. Again, you can see the sliding here of the visceral and parietal pleura, and here the sliding is less evident, but you can still see it. And to confirm the presence of sliding, you can utilize the M mode, which is one of the basic ultrasound modes, in which you could assess the motion of one area of the lung against time. So here you have a very typical pattern which confirms the presence of sliding. This is called the seashore sign, in which you have the chest wall, you have the pleura, you have the parenchyma. The chest wall is described as waves. The pleura, this bright line here, the bright white line, is described as the breakers of the waves. And then you have the very typical and specific uh, pattern here, which is the very sandy and heterogeneous pattern, which is described as the sand. So you have waves on a sandy beach or seashore sign. Why this is important? Because this confirms the presence of lung sliding, and therefore, as we will discuss shortly, this could be used to rule out pneumothorax at the point of scanning. And then moving forward to the presence of A lines, we have horizontal reverberations, as we discussed in the last two slides. These are mirror-shaped artifacts, as we said, of the pleural line at equal distance, and they move together with the sliding. But remember, they could be found in pneumothorax as well. And we talked about the loss of sliding because sliding can be used to rule out pneumothorax. And on the other hand, the absence of sliding could also be found in different conditions, not only in pneumothorax. And these are the other differential diagnoses of the loss of sliding. And this is the example here in 2D. You don't see any sliding here, but you could see a little bit of shimmering motion at the edge of the screen, which could tell you about the transition zone between the area of pneumothorax and the area of normal sliding. And the other differential diagnoses are right main stem intubation, in which you will lose sliding on the left side of the lung, on the left lung, massive atelectasis, extensive pleural fibrosis and adhesions, and cardiorespiratory arrest. So when we lose the sliding, you would expect to see a different pattern on a mode, which is called the stratosphere sign or the barcode sign, in which when you put your M mode cursor, you would not see the typical sandy pattern. Instead, you will see the very typical stratosphere or barcode, which is a mirror-shaped reflection of the chest wall. So the sandy pattern here is very important in normal sliding to rule out thorax. And then moving forward to B lines. So we talked about A lines, reflecting aeration. When you start to have the air inside the alveoli being replaced by fluid, you start to see evidence of interstitial edema. And this is seen as B lines. So B line is the sonographic sign of interstitial alveolar edema. And it has been found to correlate with the amount of extravascular lung water in patients, uh, either patients with cardiogenic or non-cardiogenic pulmonary edema. And this is how the B lines looks like. These B lines, they should typically look like a laser-like beams, starting from the pleural line until the far field, move all the way across the spectrum of the screen with the sliding. They should extend all the way until the far field of the screen. So you should not see the B lines. If you see one short line stopping here, this is not B line. And it often erases the B line, erases the A lines. When we start to see more B lines, this obscures the A lines underneath, which is an important thing to put into our consideration. But remember, as we said, because they reflect the amount of extravascular lung water, they could be found in either cardiogenic or non-cardiogenic pulmonary edema. And these are other different examples of B lines. On the left side of the screen, you could still barely see a bit of A lines underneath, but here you don't see any A lines. And remember, we look for B lines systematically on both lungs in all the described zones. So the clinical applications for the interpretation of B-lines is very important, or the use of B-lines, because we could use that in patients with heart failure, and studies have shown that B-lines could be used reliably to help in diagnosis, monitoring, therapy titration, risk stratification, and prognosis in patients with heart failure, along with other patients with renal failure and dialysis, patients with ARDS and respiratory failure, especially like cohort of COVID-19 patients and patients with interstitial lung disease. And this is an important slide because it shows you the evolving change in the aeration of the lungs concomitant with a change in the pattern of uh, scanning itself. So starting from the black normal aeration, the presence of A lines, then moving to the mild loss of aeration, in which you will start to see B lines, but you could still see A lines beneath. And then this give you the black and white pattern. And then moving to the moderate loss of aeration, in which you see confluent abundant B lines, which completely obscured the A lines, and this give you a white pattern on the screen. And finally, you see the worst degree of aeration, which is concomitant with a severe loss of aeration. And this is always happening in patients with consolidation, in which the air is replaced by tissue, in which the lung is hepatized. And the pattern is often gray when you look for patients with consolidation. So we have A pattern here, aeration, normal aeration. We have B pattern, in which you have mild to moderate loss of aeration, and you have the C pattern, the consolidation, in which you have the severe aeration. And these are different grades of the alveolar interstitial syndrome. It's important to put in our consideration that you could normally see up to 2 single B lines in one intercostal space. This is considered normal. So 3 or more B lines is often considered abnormal and pathological. And then we come to the important and £1 million question, as I call it, which is the difference between ARDS and cardiogenic pulmonary edema. Are we able to differentiate by lung ultrasound? I think we are, if we use lung ultrasound as part of an integrated approach with multiple um, imaging modalities, if we use it with echocardiography in the clinical context, with the other diagnostic laboratory modalities, we could get important information from lung ultrasound. And these are the different diagnostic criteria which differentiate both ARDS and cardiogenic pulmonary edema. So typically in ARDS, you will often see thick and irregular pleura with black hypodense areas under the pleura, which are named subpleural consolidations. And these are also very typical in COVID-19, by the way, because we know that COVID-19 is a peripheral disease, so it often involves the lungs, which makes it very vulnerable to developing a very large subpleural consolidation, as we will see shortly. You will also have patchy, irregular, non-uniform distribution of the B lines with a typical presence of the spared areas of A lines in between. This is all in ARDS. We don't see that in cardiogenic pulmonary edema. In pure hydrostatic pulmonary edema, you see a normal, healthy, thin pleural line, and you see bilateral, diffuse, and symmetrical B lines bilaterally. Unless, of course, if you have a reason for a unilateral pulmonary edema, but you would still see thin and healthy pleural line and diffuse B lines across the affected lung. And these are two slides. These are two videos from different patients. On the left side, this is a linear probe. The vascular probe, as we said earlier, the one we use to scan the pleura, thick pleural line, irregular and large hypodense subpleural consolidation. On the right side, we use the curvilinear probe here, and we could see clearly the pleural line is thin and healthy with very confluent and abundant B lines, which reflect a degree of or even alveolar edema. And another differential between both ARDS and heart failure is the presence of consolidation. So consolidation is typical for ARDS, and important to note in typical classic COVID-19 patients, we often do not see large lobar consolidation unless they are extremely sick. So among those clinical phenotypes whom they are very sick and hypoxic and have true ARDS, you will see lobar consolidation, or if they develop superadded bacterial infection. But otherwise, most of the um, SARS-CoV-2 infection patients with respiratory failure develop a moderate degree of loss of aeration, which happens in the forms of patchy B lines, as we will describe in the next slides. But we don't usually see lobar consolidation unless there is ARDS typical picture or secondary bacterial infection. But again, this is an ARDS. On the other hand, in pure hydrostatic pulmonary edema, you should not see consolidation unless there is a super added infection on top of the heart failure condition. And these are other two slides, two videos showing you the presence of pleural effusion, in which you have used the curvilinear probe or the cardiac probe phased array in the mid-axillary line, indicator to the head, and looking at the diaphragm as uh, your anatomical landmark, and the liver or the spleen, depending on which side you're scanning, and then this very black fluid structure. And you could see here the presence of the white, very white consolidation, which reflects, very white atelectasis, sorry, which reflects the evidence of probably compressive atelectasis. And this is called the jellyfish sign. And these are examples from a patients with COVID-19. This is all from the same patient, and you could see with the linear probe clearly that the pleura is very irregular and thick with large subpleural consolidation underneath. This is huge. Although this is typical for ARDS in general, but we were able to see this more often in patients with COVID because, as we said, it's a peripheral disease. And then we come to this very bright and shiny pattern of B lines, which are very often seen in COVID-19. So this is what we usually or mostly see in patients with COVID, patchy areas of B lines. You see this very white, shiny pattern. So the sector is divided into area which is black, which is the normal aeration and the preserved spared area of A lines, and there's very white. These are actually many B-lines combined together to make a curtain-like pattern of covalent B-lines. And this is a description that could be correlated to the presence of ground glass pattern on patients on the CT scan of the chest. And they reflect a degree of alveolar edema. We could also use a scoring to identify the lung ultrasound aeration, in which we could assign a score to each one of the zones that we described, and this could be useful to guide us into use ultrasound as a monitoring tool to assess the progression of aeration and recovery of those patients after they leave the unit, or in the worst conditions if they deteriorate while they're on the unit. And this is the same patient that we just saw together about 2 weeks later with the recovery of the pleura. He's quite lucky because his pleura is recovering. We are seeing patients who have residual pleural and lung pathologies, although they have survived the critical illness of COVID. And also, when we looked into this same patient's lung with the curvilinear probe, you could see the resolution of the alveolar edema, and you could barely see a few B lines peripherally, but most of his lungs were abundant normal aeration of A lines. You see the pleura here and this horizontal mirror shape artifacts. So clinical benefits of ultrasound in COVID, it could be used as an extension of clinical examination, as I believe, and therefore it could assess recruitment, and it could help also as one of the additional tools to guide the patient readiness for extubation. So in general, in COVID-19, lung ultrasound could be utilized as a triaging tool to decide where will be the direction of patient pathway in his management, whether he will be admitted to the hospital, needing intensive care management, or could be safely treated at home, depending on the clinical picture, the degree of oxygenation, and the pattern of lung ultrasound aeration. And it could also be used to risk stratify those patients, prognosticate, assess disease progression. And this is a lung ultrasound dataset which was released from the Intensive Care Society of the UK, and it is describing a flow sheet to try to reach an algorithm to help identifying which pattern of patient will benefit from proning versus those who will benefit more from positive end expiratory pressure. And the important thing is that this dataset highlights the importance of lung ultrasound as a monitoring tool to assess the response to therapy, which I believe is the most powerful thing of this tool. So at the end, I always call for an integrated approach. So we could use all the diagnostic modalities that we have. We cannot use one modality uh, in isolation. It should not replace our common sense. It should always be put in the clinical context, and we should integrate lung ultrasound with cardiac study using scanning the heart, the the big veins, looking for any venous thrombosis, looking for the venous size as well, scanning the pleura, scanning the IVC. And these are different examples of integrated approach. You have patients with hyperdynamic LV, flat IVC, and A lines. This patient is having hypovolemia. Another patient with a preserved biventricular function, dilated IVC, and the presence of a transition zone between the area of sliding and no sliding, which is described as lung point. And this is specific for pneumothorax. This patient could be diagnosed with extension pneumothorax, therefore. And this is a patient with severe biventricular disdilatation and reduction of systolic function, dilated IVC, and the presence of B lines and pleural effusion. This could be seen and as heart failure, and a patient with RV strain, dilated IVC, A lines, and a big thrombus in the femoral vein. This could be a clue to pulmonary embolism. At the end, it's very essential and important to know our limitations, because lung ultrasound may miss pathologies deep within the lungs, which is one of the limitations of this tool. And in this aspect, CT chest, of course, is better. And I would stress on that CT chest is still the gold standard imaging modality for patients with respiratory conditions. The second limitation is that the accuracy of lung ultrasound is influenced by training and experience. So training is very important, and you get better the more experience you have, like any diagnostic modality. But the good news is you don't need longer time to get trained on lung ultrasound. The third limitation is that we don't have enough robust data yet, because this is a new and evolving field in acute care imaging. And of course, especially in COVID, we have to be very mindful and careful about the potential for human transmission of patients with COVID if we don't clearly and thoroughly clean our machines and make sure that we are dedicating one machine, if possible, to our COVID zone. And this is what we were doing in our hospital and what many other clinicians were doing and what was recommended by the latest recommendations from international societies. So I will finish by my final take-home message. Be patient with COVID-19 patients who are ventilated because we know that these patients take a bit long on the ventilator. It takes a bit of time for the lesions to heal. So around 10 to 14 days is our experience for them to be ready for weaning and extubation. And therefore, lung ultrasound is very useful to monitor the improvement in aeration before extubation. It's a very new disease. It's a new disease with very limited evidence on therapies, but still we have good modalities that could be applied and integrated in our understanding and our diagnosis of this disease. Lung ultrasound can be very useful, and I would stress again on the importance of integrated approach in scanning these patients. Thank you very much for your attention.